Denise. How are you today?
Hello, Ginger. I think I always start the same way, but that's what we do. How are you?
Yeah, what's next is the weather, man.
The weather. We always talk about the weather. I'm just really glad that it's finally warm out.
Yeah, no more snow in Madison?
No. We're done hibernating, so
That's
I
good.
love it.
That's good.
Bring out the flowers.
We're going through about every Thursday, Friday. We go through these tornado experiences in Kansas and Kansas City. It's been a crazy spring for us, but I think that's true for a lot of the Midwest and the East. So.
Oh yeah, we got pelted really hard with hail. I have stories. I have pictures about wrapping up the cars. So.
All right. So we're going to jump right into new news, which a lot of people are familiar with now. And I really try hard to think about not only how can I stump Denise, but how can I tie this into our guest? And we're very excited that Neel Shah is going to be with us today, which I would say 99.9% of our listeners know who this incredible guy is. But I was up late last night getting prep done for some presentations. I'm overloaded by the end of May, and guess what popped up? The Vital Statistics Rapid Release Report number 43, April 2026. And wow. I actually had not seen this yet, Denise, but a good friend of mine, Kathleen Rice Simpson, had sort of hinted that something was floating around out there, but I hadn't found it yet. And it came up. So I'm gonna tell you some things that I think are amazing and, quite frankly, astoundingly positive.
This is great.
Yeah. And then something I'm going to just say, what the heck is going on here?
All right. Tell us what it is.
Are you ready? Okay. So I'm just going to sort of look at the graphs. The first one is the number of live births and general fertility rate. This is provisional data for 25 has all dropped. We're hearing a lot about that nationwide.
Yes.
In a variety of conversations, which we won't go into, but quite honestly, the drop from 20 to 25 is pretty significant. The next graph I want to just applaud because back in the day, when I was in active practice, we had a lot of grants for teen pregnancy. In fact, we had one at St. Luke's Hospital, Denise, when we
I remember that.
Had a teen pregnancy clinic. The rates are at an all-time low. And
yes,
that's for every category, 18 to 19, 15 to 19, and 15 to 17. It's, in fact, the lowest it's been, I think, ever.
Something's working.
Something's working. I think we know what's working.
Right.
Now I'm going to tell you what I'm really concerned about. Because
all right.
When I, before I even graduated and was an RN, I was teaching childbirth education. I was a certified Lamaze instructor. And I distinctly remember sitting on the floor in a room with 10 couples going, one of you is going to have a C-section. The rate is 1 in 10. These are some of the things we like to just help you be aware of and coping techniques to maybe reduce your chances, but it's just the way the odds are.
Yes.
You want to know what's going on in 25?
No, the way you've started it out makes me frightened, but just give it to me.
All right.
Don't make me wait.
We have not stopped going up since 2018. And the overall rate right now for cesarean delivery again went up from 32.5 to 32.4 to 32.7. So our numbers are rising. And then we look at the
NSVD.
Yeah. And it's the highest. Right. It's the highest that it's ever been at 27.2.
Okay.
So
we're going to start getting near Brazil rates here pretty soon.
Well, those we don't even want to talk about.
No, we don't.
They don't think about vaginal birth much over there.
No.
But, I think it's important. We're getting all kinds of listeners now, and even some global folks are starting to join us. What do you think? I mean, you work in the hospital, Denise, in a very high volume practice. You've got almost 19, 20 midwives. You work with residents. What's your rate?
Well, that's interesting. I think I have to look. We're still, it has slightly increased over the years, but we're still in the range of 12%.
Whoa.
So with our midwifery group. I'm not talking about,
Yeah.
the whole hospital rate.
Yeah.
But I do think if I remember correctly, it's in the like 20, maybe 27 to 28%.
Yeah.
So
Yeah.
still a little bit lower than that number.
Yeah.
Um, but I don't do the data as much as I used to. I gave that to some of the younger midwives so that they could be, well aware of how to collect that and the importance of doing that, because I do
Yeah.
think it's always very important
Yeah.
to really be aware of what your practice is doing so that you can look at what things could be changing or shifting.
Yeah.
So I actually that will be a really good thing to go back and make the comparison from 2020. But I do think some of those good stats that are coming out, come as a result of, our famous little COVID and other efforts, right?
Yeah. Yeah.
So, wow. Well, thanks for bringing that to light again. I think that is important to always keep in front of our mind.
Yeah. And it does intersect with a couple things that I came to know Dr. Shah for, and now I'm going to call you Neel from this point forward. When I was leaving the presidency of ACNM, a good friend of mine, Kara Osborne, was sort of tapping on my shoulder, and I was trying to figure out who could I really think about as a keynote in my last year. And it happened to be someone I had never heard of, and yet I understood that this person really, as a young obstetrician, was beginning to research and talk about things like cesarean birth and costs of care that nobody really, in my mind, had been bold enough to talk about before, particularly in OBGYN. And so when Neel agreed and came to that, I think, Neel, you had an overwhelming, like, standing ovation and applause. And, it was all thematic through really this idea of the cesarean section dilemma. And over those years, we've worked a lot together and are sort of circling back again on another new project that maybe we'll get to before the end of the call. But we're so honored to have you, Neel, because the midwifery world, as you know, not just domestically but globally, is under a lot of stress. The barriers, in some ways, seem to be rising, at least with our clients and what we're hearing. Costs of care have some implication for that, but so does this inability to truly mainstream this professional career track with the team. It's like you either know how to do it or you do it poorly.
Right.
So, Neel, I want Denise to say a few things, and then we'd love for you to sort of talk to us about your journey into, like, where did this voice come from? This advocacy come from? Denise, any thoughts? Anything you want to say?
Well, I just want to say also thank you, Dr. Shaw. I'll call you Neel too, if you don't mind. Whenever you join our POSPA's podcast, I mean, actually, you become such a friend. So I'm taking the liberty of calling you that. I've heard your name for many, many years, and it's always been a pleasure to hear you speak. But Ginger, you bring up some really big stressors about cost, and I think we see that in the work that we do all the time with our clients, and we this is something that needs to be really brought to light. So thank you for being here, and let's just delve into the problems.
Let's do it. I mean, can I also say that I, as a rule, do anything that Ginger asks me to do.
Wow.
Yeah, I
You joined,
also
I'm in your club.
I know, and I'm aware how dangerous that is
Yes.
because Ginger's not a
Yes.
person who takes no for an answer in general. And but I also, to the extent, Ginger, that I'm known, it's largely because of you. And I think I've been deeply honored over the years to work alongside you, learn from you, and I have found Denise fast friends in almost every midwife I've ever met in my whole career, almost like a lost tribe.
Yeah.
Oh, that's
So
amazing.
I don't know where the voice came from, Ginger. I mean, I don't even know. I don't think I was aware that it was a unique voice until I
Mm,
was in that room at ACNM a little over a decade ago.
interesting.
In that really odd mashup in Albuquerque where there was
Yeah. Yeah.
a rally for the president, the
Right.
current and former, and also midwives in the same space.
Yeah.
Um, but I think I had a sense that it was maybe an iconoclastic perspective a little bit, but I also, you know, I don't think I was aware of the history of the tension in our country
Mhm.
between these really divergent and
Mm.
often opposing views of what
Hmm.
childbirth should ideally look like. I don't think I knew. What I
Yeah.
knew was, I mean, I grew up as a son of Indian immigrants who came over on an H-1B visa in the late 1970s. Nobody knew what an H-1B visa was until
Yeah.
relatively recently, but I'm proud of that fact. And
Yes.
they were straight-laced immigrants, and so I very predictably went to medical school as an Indian kid from New Jersey, you know?
Yeah.
But then
Right.
everything after that was less predictable for me. Um, and it might be because my grandparents, they were part of decolonizing India, so they
Mm.
helped raise me and gave me, I think, a healthy respect for radical thought, even though
Yeah.
I had very rule-following, pragmatic parents. And I think maybe that's what like drew me to midwifery, because I think at least the modern version of midwifery requires working against the grain, and it requires
Oh,
being the
yeah.
kind of person, right, who sees that and does it anyway. Like Kara Osborne. She could have
Yeah.
gone to medical school. She looked
Yeah.
at that and she was like, no, I want to be a midwife. Who I
Yeah.
am as a person is a midwife.
Yeah.
And I think of the book The Giver by Lois Lowry a lot,
Yeah.
where, the book is about a society that sees everything in black and white, but there's one person who sees things in color.
Yeah.
And every time I'm with a midwife, I think they see in color and I'm not crazy. So,
Well, what's interesting too, Neil, is when you're there in Albuquerque, Liz Howard was like on the front row, right up there, and
yeah,
we
he was a big part of my struggle.
maternalistically argue over who's your midwife mother. It's Liz or
Yeah,
Ginger, but you had some great medical education training
I was
at
very
Brown.
lucky. Yeah, I was at Brown where
Yeah.
there's Women and Infants Hospital that has midwives and is one of the
Yeah.
highest volume places in the country. And that was my
Yep.
introduction to medicine. I signed up for OB/GYN first in medical school to get it over with. I
Ah.
was like, that's one I can get. I'm clearly never going to do that. Let's get it done. That'll be my way of like, getting used to the hospital. And um, that place is so busy. They do
Yeah.
10,000 deliveries a year.
Yeah.
And my first week I was on night float, which meant like I was on the overnight shift. Um, and what an introduction
Yeah. I
to
bet.
medicine. And Liz like taught me a lot, but she taught me how to sew and suture, but she also just was like my shepherd into the whole profession.
Yeah.
So it left a really
Yeah.
lasting impression on me.
Yeah.
Got very lucky that way.
So tell us a little bit about when costs of care evolved in your educational pathway, because I sort of see it coming back now, Neil. Uh,
Yeah, I see. Yep. So right in the middle of medical school, there was a freshman senator from Illinois who decided he wanted to run for president, and he had no chance of winning. Because Hillary Clinton was clearly going to be the nominee in 2008, but then
yeah.
it turns out she wasn't. And
Right.
this candidate, I think, inspired a lot of people. But one of the things that was really core to the presidential debate that year was affordability of healthcare.
Yep.
And I was taking care of people before the ACA,
Yeah.
before Obamacare, in a post-industrial New England city where very few people had deep pockets.
Yeah.
And I was seeing that we were making decisions on behalf of our patients without any idea what it cost them. Um, in hindsight, I realized that I spent hundreds of thousands of dollars as a student and as a first year doctor, but it was almost like, I was a conductor leading an orchestra that I couldn't hear
Hmm.
because I couldn't
Mm.
see any
Yeah.
of that. And
Yeah.
meanwhile, I had patients who were choosing between rent and
Yeah.
medical recommendations. So it just seemed wild to me that nobody had that insight. And I ended up starting a nonprofit that was focused on trying to get clinicians to think about affordability of healthcare and how their
Yeah.
decisions can make a difference.
Yeah.
Ah.
Yeah. And so let's go forward however many decades now, and we
Yeah.
see this whole new AMA ACOG issue rolling out about unbundling and what that does for normal healthy birth versus this potential risk of what we started with, the increased C-section rate. And where does money go? And how do patients even begin to understand what any of this truly means? I mean, it's so complex. But when you think about costs of care now over this time, the costs are going up for the patients, and the cost of services is going up for everyone. The cost of supplies, I mean, all of
Yeah.
that. Malpractice insurance rates are skyrocketing, especially in maternity care. What's your forecast? I mean,
I mean, listen, for the next 9 months, the entire public discourse is going to be about affordability in general, affordability of life,
everything.
affordability of gas, affordability of
Yeah,
groceries. But
yeah.
healthcare will be the tip of the spear, running right up to the midterm elections. And we've seen this movie a lot, right? Like this
Mhm.
happens every 10, 15 years where it boils
Yeah,
over. And,
yeah,
I was um, in the trenches during the lead up to the Affordable Care Act, but now we're, um, I don't know how many years later, decade and a half ish, right
yeah,
later. And so it's
yeah,
happening again, because lo and behold, the problem isn't solved.
yeah,
Um, and so my prediction is that that will become the catalyst for whatever follows. And there were very particular things that followed from the Obamacare era, but the things that will follow from this era are, you know, consumerism, I think is related to affordability. The
yeah,
idea that like, you know, I would have certainly not have predicted that a couple of years ago that direct-to-consumer healthcare companies would have enough money in the bank to have Super Bowl ads. But
yeah,
like once
Mhm.
yeah,
you're that big, you're probably
yeah,
going to stick around, you know?
yeah.
I don't think it's a fad. I think it's a trend. GLP-1s are not a fad.
Oh no.
They probably are to metabolic health what penicillin was to infectious disease.
There you go.
And
I
they're
agree with that.
revolutionizing everything about healthcare services.
Yeah,
Um, Not to mention the AI of it all and all that. So, I mean, I think a
yeah,
lot of what we're finding is that normal people don't want gatekeepers between them and their own health information and health services. And I think gatekeepers and middlemen are not going to have an easy time in the years to come, and for good
yeah,
reason. Yeah.
yeah,
Great.
yeah.
Hmm.
What are you thinking, Denise?
I'm just like I want to know what that's going to look like. So I think I you can't. It's not always easy to project, but I think I think middlemen are always, let's just say middle persons. They're always a problem, right? Um, mm. Is it going to be a case of asking more accountability from the consumer to insurance companies, or what is that going to look like?
I mean, I think part of what's disconcerting about the world we're entering into is that it feels like we're all standing on quicksand. Like nobody really knows, right?
Hmm.
Like we had a generation of relative stability, and then we've changed how we're paying for maternity services for the first time in a generation, and
Yeah,
it will change things for the next generation, right? Or there are all these things like that happening. So I don't know, but I do think that we always shift responsibility in healthcare onto consumers, and that impact will be inequitable.
yeah.
And also, I think my hope, or that's the pessimistic view, my optimistic view is that uh, the primary purchasers of healthcare services these days are millennials and elder millennials. And that's my generation. And we invented wellness as a
Mm,
concept. And our expectations for what we want from our healthcare system are a little bit different than the prior generation. They're higher. That made us very annoying to the generation in front of us. But I think it's leading to things like um, menopause being like an employer benefit that wasn't a thing before,
yeah,
or even the fact
yeah,
that it's even in the zeitgeist.
yeah,
Um,
yeah,
so I'm hoping there'll be more consumer empowerment that
yeah.
might come with this too. Yeah.
One of the things I'm seeing happen right now, from two perspectives, physicians are moving to concierge care. We have some clients out in California, um, midwives, but also physician practices who have just said, "I give up." Medi-Cal isn't paying enough,
Yeah.
and I need money, and this is what we're going to do. And those who can afford that, hooray! Um, but that leaves behind a lot of people. Um, and then we see in the social media, but also in midwives we're working with who want to start home birth practices, those numbers are rapidly rising. Jean DeClercq has talked about that a little bit in terms of the home birth percentage is rising significantly.
Yeah,
Not, I mean, it's not just COVID anymore. I think it's distrust, it's fear,
totally.
it's cost, it's a lot of things. And do we have a society prepared for those kinds of things happening without systems in place to be a safety net or whatever we want to call that? Like when these
I mean,
decisions are made, people are impacted.
I agree. I think part of the uncertainty that we're all feeling also is that um, people objectively feel like their lives are getting harder and that opportunity is getting smaller.
Yeah.
And they not only feel that, but it's just objectively true
Yeah.
by a lot of
Mhm.
measures, including some of the ones that you led off with from the CDC. Like C-section rates are going up,
Yeah.
maternal mortality is going up, like,
Yeah.
and that's leading to this like strong populism in the US and across the world. And populism doesn't align with the traditional parties in the same way. And so everything seems mixed up. Nobody knows,
Yeah.
like, on one hand, we're so divided. On the other hand, like, the line between being a Republican and a Democrat seems thinner than ever, or at least confusing or gerrymandered or something. And to
Yeah.
your point, like, there are a lot of things happening that are not good for like people as a whole, populations as a whole. And that's fueling this sort of populist
Yeah.
uprising.
Yeah.
And that's going to lead to massive generational change, hopefully for the better, but I don't know. And
Yeah.
that's part of what's so disconcerting about this moment.
Yeah. Well, as people try to understand, like I have four sons, as they try to better understand the healthcare system they're navigating, those that have kids and even those who don't, I mean, they're coming to me with questions that, I mean, they have no understanding
Mm.
and they're pretty smart, educated guys who are just trying to do the right thing. And when you can't get a healthcare visit for 9 months to a year, it's sort of like, what the heck is going on here?
Yeah, people deserve, I mean, of course they're mad,
Yeah.
right? And like it's so hard because, all of us have worked within what I now refer to as the incumbent system.
Mm.
Okay.
Right? And
Yeah.
like we sometimes feel defensive of its constructs
Yeah.
because we are we understand the reason for them in many cases, and the reasons can be complicated and hard to explain.
Yeah.
Um, whatever. Like the FDA is really slow, but also they make sure that things are safe,
We
and like
hope.
so, but it's
Yeah.
the same energy why like, people are going online and getting compounded peptides and stuff because the
Yeah.
FDA is too slow. And you understand
Yeah.
that too,
Yeah.
right? Like,
Right.
Yeah.
um,
I mean, I'm looking into that right now myself, to be honest with you. Yeah. I mean, I get it. Um, well, let's sort of you and I talk about this a lot with maternal mortality. How do we bring hope and action outside of the fear and the uncertainty? If you had some thoughts, and we asked Dr. Wickstrom this, a maternal fetal medicine doc that was a consultant for us in St. Luke's for years, and Denise and her have done a lot of work in Haiti together. When we think about how to help midwives improve their opportunities to engage in practice, the fragmented system that exists for many, they're barely holding on, and they're probably holding on because they need an income, and there's nowhere else to go. Do you have any thoughts or ideas about how we can change that, or what kind of steps could people take, maybe, to feel empowered to take action? It's a big question.
well, I mean, this podcast is about what's possible.
There you go.
And there's right. And so like that my instinct is to lean into that because I think at
Yeah,
this moment where the whole board seems scrambled, it is more challenging. Uh, there's more weight on our shoulders now than
yeah,
before in terms of people's well-being, in terms of structural changes in payment that are going to make things harder, and I'm sure we'll talk about.
yeah.
But there's more that's possible also. One, what a time to be alive technologically. Like, oh my gosh.
Yeah,
Like, just within the last year, there are things that I never thought would be possible. Do you
yeah.
know that this Aura Ring can predict when people go into labor?
No,
Yeah. I used to think if there was a full moon,
no.
people would go into labor. But yeah, we're like
Oh my
getting
God.
close to that being the reality. It can already predict ovulation pretty regularly. Um, we didn't know what preeclampsia was for
Yeah.
our whole existence, and now we can find a molecular signature and predict it in someone with no apparent risk factors months in advance. Um, we can type a complicated question
Yeah.
into ChatGPT or Claude and get back something pretty reasonable.
Yeah.
Um, most of us who work in maternity would have to document our notes late into the night
Yeah.
after a day in the clinic, and that's medieval now. Now we have
Yeah.
ambient listening.
Yeah.
Up to date is going away and being
Yeah.
replaced by something called open evidence. There's so much that's
Right.
changing. So, I
Right.
mean, midwives have always been people who see in color when everyone else sees in black and white. And this is a moment to lean into that capability because there's more that is possible from that standpoint.
Yeah.
Um, I also think structurally, the unbundling of the maternity code is going to lead to more volatility, but it means like, you know, I think actually there could be more leaning into innovation as a result, if that makes sense. I mean, that might seem overly optimistic, but the old bundle to me very clearly stifled innovation.
Sure.
I
It was very
regret
clear.
that we threw the baby out with the bathwater, like
Yeah.
I wish we would have replaced it with a better bundle instead of just
Yeah.
unbundling, getting rid of it, and just
Yeah.
waiting to see what happens,
Yeah.
you know?
Yeah. Yeah.
But part of what will happen is that we'll see new ways of caring for people that I hope that midwives can lead.
Yeah. I mean, I'm really glad to hear you say that because we have become avid possibilist advocates for midwives who are just like we can't afford to lose them. You know,
Yeah.
certainly doesn't take as long to train them, but we can't afford to lose them because the workforce shortage is in such a crisis right now. But I think sometimes when you're that beaten down, as an oppressed profession, it's hard to feel like anybody believes anymore. So the easiest path is to exit and, go do something else. But
Well, you spend a lot of time helping people who are feeling that
yeah, we
pain
do.
deeply, right? But okay, here's a
We
take
do.
that I'm certain of. In the AI of it all, I actually think that human connection is going to have a premium. It's a weird thing,
Mhm.
but from a pure like market forces perspective,
Yeah.
people are starved for human relationship right now. And like the building blocks of midwifery care are the most valuable service to society now and going
Mhm.
into the future, especially when we have asynchronous care and virtual
Yeah.
care and all that
Yeah.
stuff,
Yeah.
I think.
I think I just have to interject. I think that piece of that statement is the truest statement that I've heard all day, all week, all year. I really, really like on every level to my core believe that there's so much isolation. And so that I do think that is so critical. I mean, I might just have to write that down a few times, but I already feel it. I just want it to be on a t-shirt or something.
I mean, we see it in everything, right? Like
Yeah,
even like we're all
everything.
drowning in AI slop.
Yeah.
But if you see something that was authentically written by a human, you can tell it's
Oh,
better.
yeah.
Like we hold on to it, right?
Oh,
It's
yeah.
like
I
and
mean,
even more so in something so intimate as childbirth
Yeah.
and healthcare. So
Yeah.
I think there's this whole new thought about like that I've been stewing about third spaces, where the need to create third spaces is just because, you need that extra space to connect with people. So I wonder how that could translate into, this innovation concept, creating healthy third spaces, which, you know, people do like for birth centers or whatever, but I think on a bigger scale. Okay, that's
my
yeah.
my best metaphor for the moment we're living in is that there was a time that the three of us remember where Blockbuster existed, and we would go
Yes,
Yes.
there and we would
yes.
like rent VHS cassettes or DVDs.
Come
And
on,
now
you're
nobody does
you're
that.
that old, Neil? Come on.
Oh,
This
I
is
am. I am. And then, in fact, I'm old enough to have been married during that era and driven my wife nuts
oh.
because I used to love like browsing
Yeah.
and like
Yes,
she's just
yes.
just pick something already. Um, and we make a whole trip of it.
Yeah. Yeah, yeah,
Like,
yeah.
but now it's gone because we're in the streaming era, and people forget this.
Right.
But for like 2 seconds
Right.
before streaming, Netflix would mail you the DVD.
Right.
Yes, yes.
And when it comes to whatever we're headed to, uh, we're not in the streaming era, but we're in the equivalent of Netflix mailing you the DVD.
Very
Like we're
true.
seeing the glimmer.
Yeah.
of something transformative about to happen.
Yeah.
And it's kind of clear that like Blockbuster as a construct is crumbling,
Yeah.
but it's still there.
Yeah.
Right.
Yeah.
Right. Oh, okay. That's food for thought. Mm.
You know what we believe is an opportunity, and I think Leslie Rathman, who you know would talk about this much more eloquently than me, is how do we bridge? If you listen to William Ury enough, how do you sort of find the compromise or the win-win for the individual and for the institution, where what still 97% of U.S. people give birth in a hospital, is the alongside midwifery unit, which has been in the UK for a while. Now, I'm not saying they're perfect. I'm not saying that the majority of people deliver in an AMU, but women and infants has created one. I haven't been there to see it yet. I think I'm going out there in the fall to do some grand rounds, but
Hmm.
it is an exciting time to try to find a bridge. And I think I don't know if you've seen any. There aren't a lot that are actually accredited in the US. There are some that exist that don't get accreditation from CABC, but it's an idea I think we should percolate on. Low cost, midwifery led, separate hallway.
I agree. I've
Leave them
had the
alone.
opportunity to visit a
A
few.
fresh perspective, right? I feel like that's a fresh perspective. Just a
Yeah, I mean,
place
it's just
to be.
it's amazing how the setting changes people's whole frame of mind.
Yeah.
Um, you know,
Yeah.
yeah,
Um, and you can bill a hospital fee for it versus the birth centers that are falling day by day by day because they can't afford to
yeah.
keep them open.
I mean, I think that's among the kinds of ideas an enterprising midwife could go make
Yeah.
happen in this world, and
Yeah.
honestly, feels more possible today than 10 years
Yeah.
ago to me.
And another one that we talked about with Dr. Wickstrom, um, is this hub and spoke model for rural health care, rural maternity
Yes.
care, which, I think you all are doing to some degree at Maven, but taking it to the level of, let's give Denise an iPad, send her out to rural Kansas with a portable ultrasound and an NST machine and
Yeah,
stuff to draw labs, be able to connect to the home base if needed, as needed, and provide the care remotely, but in person. Um, I think there's so much potential to do that with midwives, with the workforce shortage the way it is, and these hospitals closing, with people driving 92 hours anyway, 90 minutes, 2 hours anyway to get care. It's just unsafe.
yeah, I agree. I agree. There's no replacement for the need for actual infrastructure. And there's a lot of
Yeah.
reasons why people have to drive that far that I
Yeah.
think are addressable if we cared enough to address it. But I also think that the other, like, even more proximate than predicting labor on our wearable devices is taking a re reasonable blood pressure. And like, boy, is that going to be game changing. We're
Yeah.
literally six
Yeah.
months away from
Yeah.
like a ring on your finger, taking your
Yeah.
blood pressure, and that would change
Yeah.
pregnancy management forever for the better.
Yeah. Yeah. It's just amazing how that technology can interplay with how the care model is actuated. Um,
I mean, yeah, it's just like the continuous glucose monitors for gestational diabetes or diabetes. Like it's so the biofeedback information and the way to transfer that information similar to the blood pressures. Like we should use all of these things that would be much less costly,
I
and much
agree.
more innovative.
And I think like if I had a call to action for your listeners, which I'm imagining are obviously people who are probably largely midwives or care about midwives,
yeah.
they're nerdy enough to talk about it or listen to it for, 50 minutes to an hour and um, are really thoughtful people. I think that there's been this false narrative or false dichotomy, at least, between technology and nature in childbirth. I think that sometimes we think, and it's because there are specific uses of technology that we've over-rotated on, like the C-section or the electronic fetal monitor. But
Right.
it seems like it's either all natural and you're
Yes.
reading like the horror stories about the free birth or whatever,
Right.
right, in the
Mm,
extreme, or it's like, let's go deliver in the ICU surrounded
Right.
by surgeons.
Right.
And there's got to be a way for midwives to, lead with their ability to care with humanity
Yeah.
but also embrace technologies and maybe even lead the way on how to deploy technology more responsibly.
Yeah. We don't make money, Neil. I
Yeah,
mean,
well, say more about that.
if you look at the performance that we've done for hospitals, FQHCs, midwives who want to start their own practices, if they're only doing maternity care, even if they're getting comparable physician reimbursement rates, which not all are, but many are, it's not enough revenue. They're not doing surgery. They're not doing a lot of,
Yeah,
high acuity patients, procedures, GYN, and and it's very difficult to stay above water if that's the only thing you're doing, unless you have such high volume that then you have many midwives. Let's take
right.
Denise's practice. If there's 19 midwives, you know, on the other hand, we know that midwives typically have accounts charged over $1 million a year. Most APPs do. Doesn't mean it's accounts received, and it
Yeah,
becomes even lower as you factor in reimbursement, overhead, costs, malpractice.
yeah,
So there's a very, very thin margin, and the question becomes: is it better to employ one physician surgeon than two midwives? What's the goal? Is it money or is it patient experience? It
right. And
seems to be the battle.
I mean, I think that yeah, it's very unfortunate that those things are intentional. I think it's like
Yes.
and it's
Yeah.
fueling the consumer movement, right? But I
Yeah.
also think that um it should it should be the case, ideally, that um we pay more for the services we value. That has to happen.
Yeah.
Like, we should not reimburse maternity services at a rate where you need really high volume to even break even.
Right.
Meanwhile, the cardiac ICU is like crushing it, or like the infusion center. Like it doesn't, it's all
Yeah.
backwards, right? We're talking about childbirth here.
Right.
And
Right.
also, we should be able to find ways to like maybe lean into the the overhead is a big part of what kills us.
Yes.
Right. And
Hmm.
that also
Yeah.
seems like an innovation opportunity. It seems like both
Yeah.
to me, I guess is what I'm trying to say.
Yeah.
I am really worried about midwives in this new world of January 1st,
Yeah.
2027.
So are we.
I'm curious how you're thinking about it too. But I mean, the way I see it, you know, the incentives will clearly be towards the kinds of services that you described, the higher
Yeah.
reimbursing services.
That's right.
Hmm.
And midwives seem to be attracted to helping people first and
Right.
then figuring out how to get paid later.
Right. Oh, that's for
Um,
sure.
you
They
know,
have no idea how they get paid, Neil. I shouldn't make such a broad statement, but
Many don't.
by
well,
far the
most
majority
docs
don't.
don't either, but I think like
So,
midwives are uniquely driven by the help part first.
yeah. Oh,
Hmm.
sure. Sure. Yeah. Arden
Oh,
Schwinker, who's our CFO, was on many discussions. She wasn't on the panel, although you may know Sue Kindig. She's a WHMP JD that's done a lot of stuff with the WHMP world. Sue's a good friend of mine from Missouri. Sue was on the panel, and when she realized there was not a midwife there, she makes a call to ACNM and ANA and says, "Look, we need a midwife perspective here." So Arden and I were invited to some of those calls with the full panel, and then Arden continued on into some of the final decisions. She's now free to talk about it and can do a much better job than I can probably, but everything we're forecasting of it lowering our reimbursement rates is likely true if you're caring for low risk normal patients, which many midwives do not do.
Yeah, fair enough. I also wonder though if we could use this as an opportunity to like get really smart about how billing works, and like because I mean before all we had is four codes and so we didn't
Right,
have to think about it. And now we
right,
don't have a choice but to think about
right,
it at a much more granular level,
right.
and there will be things that feel not ideal in terms of more like the AMA has to tell CMS this will be budget neutral. And so there's got to be cost shifting. That's the only way that's possible. And so the money
That's
has to go
right.
from one place to another, right?
That's right.
And bottom line, I've been talking to actuaries and all kinds of folks who wanted to look at the details of case mix and market by market geographies and all this
Right.
stuff. And like at the end of the day, like money is going to go from low risk care to high risk care. That's what's
It
going to
has
happen.
to.
And like on the low risk care in our country, we're not doing great. We're not doing great. We've got uh, uh, real challenges around access. Why? Because they were not making enough money to begin with, to your
Right.
point.
That's
And
right.
that is going to get worse, and that's going to make
Right.
access worse, particularly in certain parts of the country.
Well, what I found really interesting in some of the discussions I was on was qualifying social determinants of health as a high risk condition.
Hmm. There we go.
I mean, I will. I mean, I haven't seen it to the detail that Arden has, and I haven't asked her yet. But that was intentional. That was
Hmm.
clearly intentional. And I'm sitting there even saying, wait a minute, there are very, very healthy people who may have qualifiers of social determinants of health that do not make them high risk from
Yeah.
a medical perspective, but may end up with an obstetrician because now they've been classified as high risk.
Oh, interesting. I was actually thinking that maybe um, the midwife at the federally qualified health center might benefit from that. But I hear what you're saying too. I mean, there's also plenty of people who are
You don't know.
35 and perfectly healthy and are also
Right.
going to be labeled that way. So,
Yeah, that would have been
um,
me with Isaac. Yeah, exactly. I don't think we know yet, but we'll know more. We just posted. Arden's doing a webinar early June, and in one day we had like 40 people sign up. So we have a lot of interest that's growing very rapidly because people are concerned and they don't know where to get the information.
yeah,
So being innovative and smart, and having billers who understand the new codes versus holding up, you know, payouts for months because you
yeah,
coded something wrong.
yeah. One of my predictions also, though, like my ideal is that we would start with the best care model and then we'd figure out how to pay for that. That would be the rational
Ah,
approach. What usually happens in American public policy is we decide the payment and then we hope that the right care
make
model
it fit.
follows.
Make it
But,
fit.
you know, it, w- in this unbundling, there's going to be winners and losers for sure, but there's also going to be higher and lower performers. And one of the things that I'm hopeful about is that somebody with purchasing power will lean in, maybe in Arkansas, maybe we know people there, I don't know, somewhere in the country, and just say like, if you're willing to take risk, I'll pay you for it. So if you're willing to prove to me that by taking care of low risk people in the quote unquote right
Yeah.
way, you're going
Yeah.
to create better outcomes, and that
Yeah.
means less babies in the NICU and
Yeah.
less
Right.
cesareans, I will pay you to deliver that
So
care.
your performance measure you're talking about is outcomes, not money.
Well, I think ideally we would pay money
Yeah.
for outcomes.
Right. Right.
And
Right.
maybe
Right. I
that's
get
more
it.
possible in a world where, you have visibility into every service that's being billed.
Yeah.
And you
Yeah.
see that some people are billing for lots of high risk care, quote
Right.
unquote,
Right.
but the outcomes aren't following.
Yeah.
Or, and there are like health plans that have Vantage over all of that, where you can say, well, my patients are higher risk. And you can say, well, no, they're not, actually.
Yeah.
Right.
Yeah. Well, we have a little bit of time left before we go to that call to action. But one of the things, if you feel comfortable talking about it, you and I have circled back together now, working on a project out of Arkansas. Um, do you want to talk about that for a minute? And what's your thoughts about reducing the maternal mortality rate by half in 5 years?
Yeah, I'm very excited that the effort to address maternal health in the United States of America continues to have a lot of momentum.
Yeah.
We have a
Yeah.
world that is so crazy right now, and the news cycle is so bonkers. And in spite of all of that, the issue that you both have long championed continues to have a lot of momentum. And so, Olivia Walton, who is in the Walton family, which started Walmart, and is a philanthropist and an investor, um, is working closely with our mutual friend Kara Osborne, who
Yeah.
introduced us on an initiative to do exactly what you just said.
Yeah.
And she's going to commit philanthropic dollars. She's going to raise philanthropic dollars. I think there might be an announcement around Mother's Day that
Yeah.
quantifies some of this, but it'll be big.
Yeah.
And it has this audacious goal.
Yeah.
Um, and, like you can't you can't do anything unless you set big, audacious goals. And so why not?
Absolutely.
Like we absolutely should be able to cut our maternal mortality rate in half on any time scale, especially when you look at our peer countries.
Yeah.
So I'm really grateful for them and their leadership and stepping up. And
Yeah.
I'm really honored that you and I and other friends of ours are going to be around the table to help them think through how they're going to do that. But a big part of that, Ginger, which
Yeah.
you both are uniquely qualified to lean into, is one of their three pillars is making the business incentives better aligned.
Right.
Hmm.
Right. Right. Well, and I think they have taken a spin, if I understand all of this correctly, to engage in with intention businesses to sort
Yes.
of step up to the plate.
Yeah, I mean, Walmart has a baby every 8 minutes
Oh my
somewhere in
God,
America,
I didn't know
right?
that.
Like think about that for a second.
Is that
If they,
global or US?
that's across their whole employed population, but
Okay.
Amazon has a baby every 12 minutes,
Oh my God.
and so
Wow.
we have not traditionally thought this way though.
No, we haven't. I mean, which is what's so damn exciting, to be honest with you. It's
Yeah,
like,
and by the
okay, we
way, with everything that we've talked about, their costs are going to go up like 5 to 10% year over year just because of the unbundling. That's a lot of money for those businesses that are also dealing with supply chain
yeah,
issues and gas
right,
prices and all that, right? So
right.
they have a stake in this.
Yeah,
Um, so yeah,
yeah. It's exciting. More to
Mhm.
come. I think on our Buzzsprout website, Denise, I'll put what we can about um, the initiative that is available on the website, but also some other stuff Neil's talked about. We can share.
I really appreciate this is like a little bit of glimmer of hope. I'm sitting here in the seat as a very clinically focused midwife, and we work many, many hours, and taking the time to sit and think of innovative strategies is it's not there's no time to do that. So we keep plugging along, trying to just do the work that we do really well. But when we do hear of some of these potential new projects, it does provide the hope that we need,
Yeah,
and it does really encourage people to really bring up the dialogue and to be connected to push forward on some of these things. So I think the people out in the workforce need this hope for real.
yeah,
I absolutely agree.
I understand that. I mean, my personal litmus test for character has always been if you come to a fork in the road and there's like the right way and the easy way, which way do you go? And again, it's the whole against the grain thing that midwives do so well, but we really need you.
Yeah,
And I have so much empathy for how hard it is, but we're like all counting on you to keep going. And we're collectively, I really do think on the cusp of figuring out some important things because even though things seem very, very hard right now, they always get harder before they get
yeah.
easier.
I absolutely believe that.
And something transformative is going to happen, hopefully for the better.
Yeah.
Yes.
And I want
Yes.
to live to
Perfect.
see it. So let's get going.
Yeah.
Yeah. We want you
Neil,
to live to see it, Ginger.
we're going to end with a call to action. We usually start with our guests. Is there one thing that you would sort of like to leave with the midwives, especially the midwives that are listening, that maybe I don't know could motivate them, incentivize them, lift them up? I don't know. What do you think?
I mean, I think it's what we've been talking about, but like maybe to restate, midwives hold on to deep truths that are timeless. Hold on to them
Mm.
steadfastly.
Yeah,
Also, loosen some of your ideas too, because we're all standing on quicksand right now and we have to be
yeah,
nimble, right? And that
yeah,
means like if you're a younger midwife that's entering into practice, if you have a choice between maintaining a legacy system and joining the tidal wave of what's coming next, lean into the tidal wave.
yeah,
And if you're a really seasoned midwife and you've been around for a while, um, do your best to think flexibly about some of the stuff that's coming. Um, that includes AI, that includes direct-to-consumer platforms. I know it's scary. A lot of it seems like the Wild West. A lot of it you may vehemently disagree with. I certainly do. But we should really try to understand like why they're happening
hmm
and make some space for them because ultimately these disruptions are what we need to get to a better system, I think.
yeah. Great
Mm.
advice, Denise. I'm going to go last, so why don't you go next?
I have to say one thing about to your call to action, which I'm fighting with. There's a lot of the newer midwives that are coming out is they're very vehemently opposed to AI, not the older midwives, the newer midwives,
Interesting.
because of the cost, the use of water, all the things that I absolutely do not understand how that works. So I'm, as the older midwife, the oldest, longest in our practice, there's just big pushback against that. And even the children are saying, like, don't use AI. So anyway, that's for a whole different discussion. But I love that you give me permission to do that.
Yeah.
I'm taking it as permission because I have really enjoyed what I say is like, thank you for giving us a chance to do more now with AI that we never could do before. Like, it's the whole case of we work so much harder. We walked 20 miles to school and you know, you're doing online courses.
Yeah.
That analogy a little bit. So,
Yeah.
anyway, I have to think a lot about what you just said and come to terms with it. But is it my call to action? Ugh,
Yeah.
this one's a hard one because I I feel a little bit like it's frightful what I think is coming. So I have to always go back to what can small groups of people do together, in my firm belief in connection and how important that is. So again, it comes down to what can I individually do as a midwife in a very much growing practice to keep my own practice colleagues, aware and interested and invested in looking at innovation, just within our own practice, but really within our state. So
Yeah.
I think it's just my call to action is really like continue to do the work of the one-on-one, one-on-two, one-on-three
Yeah.
moving
Yeah.
forward of awareness and then creativity going into that.
One of the things you said, Neil, really resonates with me, and I think I heard it right, which is our profession is unique. There is a reason why our outcomes historically, globally, are what they are. There's a reason why we need, a million more midwives in the world because we save lives. And there is something about the midwifery model of care that gets chipped away at, but for a lot of reasons. And it's very, very difficult to defend how each of us might describe the midwifery model of care without appearing to accuse people that they're physician extenders. Denise, you and I have talked about this before, right?
Yes.
How do
Yes.
we continue to believe in that model of care as we go forward? I think there are always compromises, right? You can't always sort of, from myself and practices that I was in for 25 years, I couldn't always do everything I believed was evidence-based and should be done. But at least I held the banner of what midwife-led care was and the why, the evidence, which
Why?
continues to be demonstrated in far more studies than we need. I'm so sick of studies. Give the money to the answers. But I would say for people to really don't be afraid to champion the midwifery model of care and continue to educate. We still have far too many people, including someone, real quick story. Joe and I were in DC for an ABA meeting. We went to probably the best restaurant in DC with his publications board that he's the chair of. And there's a attorney there, probably my age, excitedly telling us she was running for US Congress, for Senate. And I'm like, whoa, And somewhere in the conversation with three Black women sitting across from us, attorneys, I bring up maternal mortality. And she looks and says, I didn't think there was a problem, the one running
Wow.
for Senate. And I just very respectfully lost it in the best way that I could to educate her. But we are a hidden secret. We still are a hidden component of what's possible. And you inspired me today, Neel. So I'm not going to stop, just not.
We need a pit version of midwifery to be real and true. Like I really think we need a Noah Wiley, but maybe a midwife version. You know,
There's work on that. There's someone that Neel, who worked with Christy Turlington as a journalist for years, who became a midwife.
Uh-huh.
who's working with people producing the pit on a midwife storyline.
Ooh, that's very exciting.
It's very exciting. Yeah. So things
Well,
are
that's
happening.
new news,
Things
Ginger.
are
That's
I
new
can't
news.
disclose a lot. I don't want this person to sort of get in trouble, but you might know
Okay.
who I'm talking about, Neil.
Yes.
Very close friend of Christy's. In fact, they're hanging out together this weekend in California. But thank
Okay.
you so very much for being on with us, Neil. We could not just be happier for your time. You're extraordinarily busy, but more
Oh, anytime,
importantly,
anytime. This fills me up too. I'm leaving just as inspired. I miss all the opportunities
uh,
to connect. And by the way, I heard that you're coming to Providence, and you know I live 20 minutes away now from Providence, so I expect you to come over when you're in town.
Oh, there you go, Ginger.
all right.
Thank you so much. I really enjoyed spending time with you,
Likewise, Denise.
picking your brain and being inspired. And yeah, we're in this together. So
Absolutely.
All right, guys. Thanks again. Have a great
Have a
thank
day.
great
you.
day.